we are now talking about eclampsia, which is falling under hypertensive disorders in pregnancy, part 3. So this is the continuation for the hypertensive disorders. Okay, so if you haven't watched the other videos, you have to watch because we started from part 1, part 2, now we are on part 3. So this is the last part. Definitions for preeclampsia. So eclampsia can be defined as the development of convulsions in a pre-existing preeclampsia patient, or it may appear unexpected in a patient with minimally elevated blood pressure and no proteinuria. Or you can define it as the presence of tonic-clonic convulsions in a woman with preeclampsia and in the absence of any other identifiable cause. The exact cause or etiology for eclampsia is unknown, but cerebral ischemia and edema were suggested, and that the timing of an eclamptic seizure can be antepartum, so being the highest at 53%, then intrapartum being the lowest at 19%, or postpartum being the second from last at 28%. So these are the timing of eclamptic seizures, their occurrence. So management of eclampsia, we have principles to make the management easier. So the first principle is you have to do general measures, and the general measures include you have to do your airway breathing and secretion. So these are the resuscitative measures. So you have to do a head down tilt for helping the drainage of bronchial secretions. You have to frequently change the position of the patient. You also have to keep the upper respiratory tract clear by aspiration of mucus through a plastic airway. So you can use your pharyngeal airway to even keep the tongue from falling back. Then you can give your prophylactic antibiotics, and oxygen should be administered during and after fits. Then also you have to, maybe if you are to sedate the patient, you have to use a self-retained this should happen after sedation. You have to use a self-retained Foley's catheter so that you monitor urine. You also have to take note of the proteinuria, hematuria, and specific gravity. Then, of course, you have to observe the maternal pulse, temperature, pressure, respiratory rate, tendon reflexes, number of fits, duration of coma, the uterine contractions. All these you have to take note under general measures. Then, of course, not forgetting the fetal athlete. You also have to take note of it. Then on the stopping and preventing convulsions, the drug of choice is the magnesium sulfate because it is more effective in preventing recurrent seizures than phenytoin or diazepam. That's the drug of choice for doing that, and you have to give it in terms of loading dose to stop the seizures and the maintenance dose to prevent recurrence of seizures, and you have to continue the magnesium sulfate for 24 hours post delivery or from the last fit. Then the other principle, which said number three, which is saying control blood pressure. So you have to control the blood pressure, of course, with antihypertensives, so nifedipine and methyldopa, like we said in the previous video. Then as well, if the diastolic blood pressure is more than 110, you have to administer a fast acting. So you have to administer adrenaline, let's say 5 milligrams IV slowly over 15 minutes, over 5 to 15 minutes. That's the dose. Then you have to repeat every 30 minutes as need arise, but I'm guessing the dose depends, it's variable per local guidelines, so you have to follow your local guidelines. Then the other principle, number 4, which is the last principle, which says you have to deliver within 12 hours regardless of the gestation age, or you have to deliver within 12 hours from last fit. So that's the other principle management. And like we said earlier in the other tutorial video for preeclampsia, the fastest way we can deliver in a patient with eclampsia, the current thinkings are towards cesarean section, but that's for you to actually decide, because that their way of thinking that the high blood pressure can be dangerous both for the mother and the fetus, and so that's why they're preferring for the cesarean section. Magnesium sulfate. So the best way to learn something is to know its origin. So let's start with the origin of magnesium sulfate, that we understand where we come from. So magnesium sulfate was first introduced to control convulsions in 1925, but it was the collaborative eclampsia trial in 1995 that confirmed the efficacy of magnesium sulfate in the treatment of severe preeclampsia and eclampsia. Then by the trial, also called the Magpie trial, that determined its efficacy and safety. So that was the brief history on the introduction of magnesium sulfate, how they started testing for it in a lot of women in different states, and they actually determined its efficacy using this Magpie trial. The mechanism of action for magnesium sulfate is not completely understood. It is thought to cause dilatation of cerebral blood pressure, thus reducing cerebral ischemia. It is also thought that the magnesium blocks calcium receptors by inhibiting N-methyl D-aspartate receptors in the brain. Then magnesium also produces a peripheral, predominantly arteriolar vasodilatation, thus reducing the blood pressure. Then it also acts competitively in blocking the entry of calcium into the synaptic endings, thus altering the neuromuscular transmission. Magnesium sulfate regimens are principally, we have two main regimens available for the administration of magnesium sulfate, and in the pre-charge regimen, the loading dose of 4 grams of magnesium sulfate is given slowly intravenously over 5 to 10 minutes, and this is followed by 10 grams given intramuscularly, 5 grams in each buttocks, so that's equal to 10. Then after you have given that, you also have to give the maintenance one, which is 5 grams IM into alternative buttocks every 4 hours. Then in the Zuspan regimen, the loading dose consists of an initial intravenous dose of 4 grams slowly over 5 to 10 minutes, followed by a maintenance dose of 1 to 2 grams every hour given by an infusion pump. So these are the two common used regimens, and here we usually use in our setup, we usually use the Pritchard regime. Calculations for magnesium sulfate, or abbreviated as mag sulfate administration. So that's for administration. So we are going to use the common one which we use here in our setup, which is the Pritchard regime. So in total, we start with the loading dose, then we do the maintenance dose. So how do we calculate the loading dose? So in total, the loading dose is equal to, or the total we give in loading dose is 14 grams in total. Then it is divided. So we first give the 4 gram IV of 20% magnesium sulfate. So that's for 20% magnesium sulfate. Then we also have to give the other, remember we said we are going to give 14 grams, so the remaining is 10 grams. So how do we give? We divide it into 2, so we give 5 grams and also 5 grams. Then this one is different because we give it IM, is intramuscular, then on alternative buttocks, so give 5M on the other buttocks. Also you have to give the other 5 on the other buttock. Then in addition to you, before giving it, you have to mix it with a lignocaine. So you have to mix it with 1 ml of 2% lignocaine. So that's 2% lignocaine. That's what you are going to use. So this is the magnesium sulfate loading dose total. Now the difference is that for the 10 for these two, the 5 grams each, we use, and in our setup we have 50%, and this same one, the 5 gram, if you remember 4 gram I said is 20%, then 5 gram we use magnesium sulfate 50%, 5 gram 5 gram. So in our setup we have 50% magnesium sulfate, and we don't usually have the 20% one. So in short, what I'm saying is, when giving the 5 gram IM, we don't dilute, so we give it undiluted. But when we are giving the 4 gram IV, we have to dilute it. So there's a formula for diluting it, so we are going to go through that formula as well. So let me go through how to give the undiluted mag sulfate, the 5 gram part. Then after that we are going to go through the one for 4 gram. So what it means when we say 50% magnesium sulfate in an ampule, so it just means that 50% of magnesium sulfate is equal to 500 milligrams of mag sulfate itself per mil. So that's per mil. So that's this is what it contains. So 50% of mag sulfate contains 500 milligrams of mag sulfate per mil. Now in an ampule, it's 10 mil, so the ampule is 10 mils. So it means you have to multiply this 500 times the this the 10 mil in total. The ampule is the ampule we have in our setup is 10 mils. So it's 10 mils times the 500. So it's going to give us 500 milligrams of mag sulfate total in an ampule. So what I'm saying is, so the 10 mils we have in our setup is equal to 5,000 milligrams. But so let's just convert that to grams. So the 10 mil is equal to 5 grams. So what it means is that when we want to give the 5 gram intramuscular, so we just have to get 10 mil of this 50% and add the 1%, 1 mil of 2% lignocaine, and give it IM. So just get 10%, just get 10 mil of the 50%, that because the 10 mil is equivalent to 5 grams. So this is for 50%, contains 50%, contains 50%. So I just have to give IM, since there is no conversion, there is no adding water for injection, not diluting in short. So now we have to calculate for the one for 4 gram, the one which is supposed to be given IV 20%. So let's calculate. There is a formula for calculating that. So now for the 4 gram IV, so remember the other 4 gram IV, we are supposed to give it 20%, and the one we have on the word is 50%. It's 50%. 50%. So how do we make this 50% into 20%? So what we do, we before we make it into the 20%, we first find how many meals we can get from the 50%. That will be equivalent to the 4 grams. So use the same principle we found. We said that 10 mil. Previously, we said that 10 mil is equal to what? If you remember, it's 5 grams, right? Yeah. Then, how many meals we will make 4 grams? So let's do some math. So this is, if you cross multiply here, it's going to give you your 10 times 4 over the 5, which is going to give us 8. It wasn't looking like an 8. So yeah, I think this one looks like an 8. Yeah, so that's 8 meals. So the x here is equal to 8 meals. So it means that if you draw 8 meals from the 50% magnesium sulfate, it's the one which is equivalent to 4 grams. So there you have it. Now, this 4 grams, or this 8 meals rather, is still 50%. So after drawing this 8 meals, it's still 50%. We haven't actually made it into 20%. So how do you actually convert this 8 mil, which contains 50%, into 20%? So that's what we are going to now go through. So there is a formula for calculating, for changing 50% to 20%. So just remember that we have found that 4 gram, you have to draw 8 mils. So remember this. So in order to avoid forgetting, maybe let me just write what we found out. So we found out that 4 gram of 50% is equal to 8 mils. 8 mils. So at least, so that you know that the 4 gram, the one we give IV. So don't forget. There's a formula for actually converting this 50% into 20%. It's the one we are going to go through here. So the formula is like, we use a variable concentration. So the one we usually common have on the words is the 50% one, which is the variable concentration. Then you have to divide it by the required one. So we know that what we want is the 20%. Then all these you have to subtract from 1. So let's make do. So this is going to be, so like I said, the variable concentration on E in our setup is 50. Then the one we want is 20%. 20% minus 1. So this is going to give us, so this is, so it's going to give us 2.5 minus 1, which is going to be equal to 1.5. So this 1.5 just means that for every mu of the calcium which is available, we have to multiply it by 1.5. Then the answer we're going to get, that's the water for injection or the dextrose 5% we are going to have. So for every mu of the available concentration, so this is the available concentration, which is the 50%. Now it's 8 mils. So for every mils of this, for every 8 mils, we have to multiply it with 1.5 to have the one we are going to dilute it with. So what I'm saying is, for every 8 mils, we should add 1.5 of either dextrose 5%, but most common we use water for injection. But just in case maybe it's not available, we use dextrose 5%. So 8.5. So let's do our calculations. This is equal to 0.58. Okay, so this is going to be equal to 12 mils. 12 mils. So this is 12 mils. So like I said, either you use water for injection or use dextrose 5%. So that's 5%. Dextrose 5%. Okay. So this is the addition to this. So in conclusion, we are going to add the 8 mils of 8 mils of 50% dextrose, 50% mag sulfate plus the 12 mils. So 12 mils either water for injection, but preferably water for injection. Then after we add this, so this is more like diluting now. So the answer is going to be 20 mils. So it's 20 mils. So what just means is that this 20 mils has now become 20% mag sulfate. So that's the conversion. So we have now converted the 4 gram. So this is the 4 gram now. So the 4 gram is now equal to 20 mils. But we remember that the 4 gram was equal to what? 8 mils. Then 8 mils, we added 12 mils. Then it now became this 20 mils of 20% now of magnesium sulfate. So this is the loading dose. So loading dose, remember, we give the 4 gram. The 4 gram is IV. Then IV should be 20%. So we've calculated. Then after we said in total it's 14 grams. So the 4 grams, when you give the 4 grams, the 10 gram have to give it 5 gram IV. And IM, 5 gram IM on alternative buttocks. So 5 gram on the other buttocks, then the other buttocks also 5 grams alternatively. So that's how you give. So I think we are now done with the loading dose. Then after you give the loading dose, if the conversion recur, you have to administer 2 gram IV magnesium sulfate. So on the last part, we are just going to go through how to also do the calculation for 2 gram now. So we said that if conversions recur, you have to give 2 gram IV mag sulfate. So remember our conversion rate was saying that 10 mils, this is for 50%. 10 mils is equal to 5 gram, since the one which is available in this setup. So now we have what? 2 grams. We want 2 grams. How many mils can we get? So that's the conversion now. So this is going to be 10 times 2 divided by 5, which is going to give me 4 mils. 4 mils. So 4 mils is the 2 grams. Now the 4 mils is still 50%. It's still 50%. So how do I change it from 50% to 20%? Since, like I said, we're giving it what? IV. So this happens if seizures recur. So since we are giving it IV, we are going to say the conversion rate. Remember what we said? We said that for every mil of the 50% magnesium sulfate, you have to multiply by 1.5 mil of the solution we are going to dilute it with. So in short, what we are saying is the 1.5 mil times the 4 mil we got, which is equal to 6 mils. So this is equal to 6 mils. 6 mils. Now this 6 mils is for the dilution. So this is the conversion we're going. This is the mils you are going to dilute with the 4 mils 50% dextro mag sulfate. So we are going to use 6 mils of water for injection, then add it to 4 mils of 50% magnesium sulfate. So this is 6 mils plus 4 mils, which is giving us 10 mils, So in short, what we've just done is that we have added 6 mils water for injection plus 4 mils of magnesium sulfate, which is 50%. And after we add these two, we are going to have 10 mils of magnesium sulfate. But the 10 mils of magnesium sulfate is still equivalent to 2 grams, just that it's now 20%. So this in total is, so the 10 mil here, 10 mils is equal to 2 gram mag sulfate, 2 gram mag sulfate, and we are going to give it IV. So this is the calculations, and it marks the end of the calculations. So there are some times where you overdose the calculations and the like, so you have to know the signs of toxicity. So this is 20%, don't forget it, 20%, now become 20%. So if you give, in the previous calculations we are making, so if you were to give too much of magnesium sulfate, you can cause magnesium sulfate toxicity. So the signs of magnesium sulfate toxicity are: 1, we have the loss of patella deep tendon reflexes. So this is the first thing to go if there is a magnesium sulfate toxicity. So you have to check for it. It should be present normally. Then the second thing is the respiratory depression. So if you have to count the respiratory rate, and normal should be, in adults, should be more than 16 breaths per minute. So that's the normal. So you have to make sure it's more than that. Then the other thing is reduced urine output. So there is oliguria. So make sure when, after inserting the catheter to monitor urine output, you have to make sure that there should be more than 30 mils per hour. That's the normal. So if there's less than that, then there's oliguria, which means there's a sign of magnesium sulfate toxicity. Then the antidote, if you are to find the toxicity signs, the antidote you have to give is calcium gluconate, and you have to administer 1 gram of 10% of this same calcium gluconate IV slowly over 5 to 10 minutes.